Thanks, Ben. Thanks so much to all of you for inviting me to join you today. I have to say that, the idea of speaking at a plenary following John Ralston Saul and Armine Yalnizyan is enough to strike fear into the heart of the bravest public speaker, but I decided that there were two ways that I could handle that. The first was to quake in my boots, and the second would be to steal shamelessly from their material and present it as my own, which is what the strategy I decided to go with. And so what I hope to do over the course of this conversation today is to draw from some of the highlights of my own learning from listening to the speeches last night and this morning, and attempting to give credit as I do so, but to bring us down to a more granular level than we've been on so far. I want to talk about how to save Medicare. And I think that actually it is not an understatement to say that Medicare today is at risk in Canada, and I would put it to you that Medicare is probably more at risk in Alberta, depending on what happens on Monday, than it has been in quite some time. And so you have a big fight ahead of you. And what you learned from last night and from this morning and from our discussion this afternoon, I hope will be both an inspiration but also useful in that fight. So today we're going to talk about how the shift hits the fan, folks, because that's what's happening here. And with that, see if the clicker will do its job. I thought to myself it was perhaps a bad idea to use PowerPoint. That would be great. If you wouldn't mind, that would be wonderful. Thank you. There must be a down arrow or a side arrow or... Page down. Perfect. Okay, I got the right button. Perfect. So what we're going to talk about, I'd like to bring us back to why we have Medicare in Canada, what it is and why we've got it, because I think it's important always to begin by grounding ourselves in the values and the evidence that have shaped this grand social experiment we call our public health care system. I'm going to talk about what the shift is, what the fan is, and what the messy consequences are that we can expect from the meeting of those two phenomena. And then lastly, I'm going to talk about what to do about it. So why do we have Medicare? I'm going to begin actually by defining what it is, because actually you may recall that Medicare, as it turns out, is not really a very sexy thing at all. Medicare is really just an insurance program. And in fact, Medicare, by definition, is really just a single-payer public insurance program for doctor and hospital services. That's all it is. And anything else that you have in this province, paid for publicly in the healthcare sector, is by the grace of your provincial government. It is not spoken to in the Canada Health Act. Whether those services are delivered in a not-for-profit hospital or in a corporate for-profit American chain is not spoken to in the Canada Health Act. Medicare is really just a word, while it conjures up visions of something grand, it's really just a word for the federal government gives you right now about 25% of the cash that you need to run your system, and in exchange it requires that you have a public insurance plan, and that's it. So it doesn't sound like much, but we have it for two very important reasons. And going back to Romano and beyond, the many commissions that have studied why it is we have Medicare, there are really two essential reasons. And the first is one that would, I think, speak to the heart of the woman who asked the question earlier this morning about how do we overcome greed and speak to the higher purpose in ourselves, and that is equity. Medicare is really a way of embodying the notion that access to healthcare should be based on one's need, not one's ability to pay. It's about having a single payer and a single line for healthcare services, and allotting those services or allocating those services based on the degree of clinical need. And that is the fundamental value that underpins the notion of a single payer publicly funded healthcare system. It is not, by the way, a value you should take for granted. It is not a value that is shared by all peoples and all nations in the world. And it is not a value that we should assume will endure in Canada, because I would say to you, and I will say this again later, that support for that value and support for Medicare is contingent upon the system actually working for people when they need it. If when people get sick or their loved ones get sick, the healthcare system does not provide for them what they need, their support for that notion of equity will evaporate rapidly. And that's something that I'm going to come back to, because there are forces that understand that and that will push to ensure that the system is not actually able to live up to those expectations, thereby creating a market for an alternative. So that's the justification, is equity of access, but happily there's another justification, and that is that Medicare actually is cheap. It is dirt cheap to administer. There is no system that costs less than a single-payer insurance program. The elegance of having a single payer allows us to spend in our provincial programs in Canada 1.3 cents on the dollar on administration. In the US, that number is close to 31 cents. So when you put multiple payers into a system, it costs a lot of money to administer, because you have to have millions of people who go to work every day to answer the question, who pays, right? The bean counters. Do you have Red Cross, Blue Cross, Green Cross, Gold Cross? Do you have a co-payment, not a co-payment? They cover this doctor, don't cover that doctor. They cover an MRI on your left side, but not your right side. They paid, they didn't pay, we gotta go after them, send them a bill, a collection agency. All of that costs money. All of that is people's work and time and salaries going in to answer that question. When there is one bill and a single payer, it's incredibly simple to administer, and so any move to a multi-payer system undermines that fundamental administrative inefficiency. So really Medicare is a happy intersection where values and evidence meet. And what I'm going to talk about today is how we need to build upon both the values and the evidence. But let's first talk about the shift. I don't know, are you able to read that slide? It's not looking so great. I'm going to read it to you in that case. Hear me? Testing? Yes. Happily, I'm loud. I'm sure you can hear me just fine. So, it used to be that the arguments against Canadian Medicare and the arguments by for-profit forces in Canada had what I would call a fairly unsophisticated message. They argued, and this has bubbled to the surface and then gone down to the depths on a number of occasions in history, but as recently as 5 years ago, when Brian Day was the president of the CMA, we had very passionate advocates on the front page of the newspapers in this country saying to you, people who are wealthy, or even who are not wealthy but choose to spend their money on care, have a right to purchase that care for themselves. And that was fundamentally the argument that was put forward. And interestingly, what those folks found was that that was not a message that resonated with Canadians. Canadians were uncomfortable with the notion that having wealth would buy you access to something better or something faster. And so what we've seen now is a shift, or a move across a spectrum to a new set of arguments. And those arguments, moving along from we just have a God-given right to pay for whatever we want, move then into this notion that, well, it may not be our ideal, but the public system is clearly broken and it can't be fixed. Look at the wait times. It's outrageous. People are dying on the streets. They're dying in pain, waiting for their hip replacement, and so we cannot possibly, as nice an idea as it was, it simply has failed, folks. So we're sorry, but we're going to have to say goodbye to Medicare. But then what happened after the 2003-2004 health accords? Some more money flowed into the system, some political will flowed into the system, and we started to see change. And lo and behold, the wait times went down. And lo and behold, satisfaction with the Canadian healthcare system went up. And it turned out actually that you didn't have to let people pay their way to the front of the line. With a little bit of money and a little bit of coordination and a little bit of political will, you could achieve some results in Canadian healthcare. So they realized that that wasn't going to work. So then they moved to public hospitals are inefficient. For-profit clinics, because they have that profit motive, know how to run things efficiently. So what we need to do, it's not that we're against Medicare, we're just in favor of efficiency. And so we're going to move all healthcare services into the for-profit sector. And by the way, I don't know if you've noticed, but there's this massive demographic shift. And the baby boomers, let's face it, they're going to break the bank. Yep. And they're going to cost us all a fortune. And so Medicare, as nice an idea as it is unsustainable. And that is the current sheep that this wolf is wearing. It's the unsustainability sheep. And you might as well recognize it for what it is, because you are going to see it over and over and over again. What Bob Evans at UBC calls these healthcare zombies, right? A policy zombie is an idea that you keep killing, but it keeps rising again. And it doesn't matter how many times you drive a stake through its heart, the zombie continues to rise. The answer to all of these is two-tiered, for-profit healthcare. They're just changing the argument to something new. They're throwing things at the wall to see what sticks. And that is the shift that's occurring, and you are seeing it loud and clear in this provincial election. It's the shift in dialogue coming from the right that you need to be aware of, because you need to know how to respond to it. So that's the shift. Let's talk about the fan. The fan, folks, and I know that this may or may not fly in an Alberta audience, the fan is we've got no federal leadership in our healthcare system, and it's a big problem. Yes. We have a federal government that slapped 6% for a few years on the table, walked away from an opportunity to have a new health report in 2014, has expressed no interest, in fact has explicitly expressed non-interest in setting any national standards for where healthcare reform is headed in this country, and has no vision for the future of Medicare other than that the federal government should have no role in it. Now, this perception that there is no need for a federal rule is an act of violence to our healthcare systems across the country, because without federal leadership, without accountability, without strings attached to the federal dollars that flow to the provinces, there will not be positive change in the healthcare system. And to the degree that there is, it will be totally different from jurisdiction to jurisdiction. So any dream that you have, yeah. Any dream that you may have of a pan-Canadian program, a national program where people from coast to coast to coast can expect some comparable level of healthcare services, no matter where they are on the basis that they are Canadian, disintegrates when the federal government refuses to play a role. So that is the fan, and we're in big trouble on it. So the consequences are essentially that we have now the establishment of per capita healthcare transfers from the federal government to the provinces, which completely undermines our history of true equity in our funding formula. And we have a healthcare system whose future is now entirely in the hands of the provincial governments. So you better be worried about that, because you've got an election coming that's going to dictate the future with a federal government that is entirely uninterested in what your government does to Alberta's healthcare system. And there is no serious talk anywhere about expanding Medicare, and no real interest in defending the Canada Health Act. So that, my friends, is going to be up to us. So what can we do about it? Well, here's where I steal from Armin. What I call recognize the rhetoric and return to the values, Armin calls expose. And we're going to talk about exposing, opposing, and proposing as we go through. What I call know and know how to use the evidence to marshal it in support of what you know needs to happen is what Armin calls oppose. And what I call offering an alternative is what she calls propose. And so really, we're all on the same page here. We cannot choose to do just one of these things, or we lose the game before we begin. So let's talk about each step. And I'm going to use the notion of sustainability or unsustainability as the thread through which I will try to illustrate what it is I'm talking about here. Also because I think some of you may be interested in some of the evidence on sustainability of the healthcare system. So I just want to check in, is the unsustainability argument happening in Alberta? Yes. Because you know that you're very rich. Oh, yeah. You've heard that? So I'll tell you how it works in Ontario. The argument goes something like this. Healthcare is the Pac-Man of provincial budgets. It is eating its way across the screen. And if we continue at this rate, it will eat up all of public education and all social programs, and there won't be any daycares left in the province, and there won't be any roads. We'll just have one massive Ministry of Health, because healthcare as a proportion of provincial budgets is uncontrollable, and it's an unsustainable situation that we find ourselves in. So that is the rhetoric, and we need first and foremost to recognize that this is the same old zombie in a different costume, if you will. And I want to come back to Armin's advice earlier. We have to ask ourselves, who benefits from this language? who benefits from this rhetoric and who loses. And we need to be very clear in our own hearts about who the winners and losers are. Now this can get very uncomfortable, as introspection can often be, right? So it's all very well and fine for us to say this is about corporate winners and everybody else losing. But I would put it to you that amongst ourselves, there are also winners and losers as we move to new models of care. And if we do know better than the other side in framing every issue as a patient care issue, then we're really no better than the other guys, and we're not exposing anything. So let's talk about the values that are at stake. Can you take us to the values? Okay, thank you. So the values, I'll put out a few. I'm sure you could think of a few more. I would say equity of access is a value we believe in, and that is linked to the notion of care free at the point of service. We believe in quality, care of the highest quality. We believe in reasonable costs and getting a good price or good value for the money that we spend. And we believe in good jobs for people. Now this is where it gets a little tricky, right? Because those of us on the left sometimes like to dress up the good jobs as a quality issue, an equity issue, or a care free of charges issue. And sometimes it is, but sometimes it's just about good jobs. And there's nothing wrong with a good job that pays a living wage. But it gets tricky because part of what I'm going to talk about later on is the movement of some care from hospital into the community, which happens to be a move that I believe in and that I believe is best for what patients need, and I believe it's actually what Canadians want. If that move is into the for-profit sector, we're in big trouble. It needs to stay in the not-for-profit sector, but part of the reason why moving care into the community is cheaper is because the workers who work in the community get paid less. Now, is that an argument for keeping all care in the hospital? In my view, it is not. In my view, it's an argument for organizing home care workers, organizing care workers, and negotiating a living wage for those people. But it is, I would say, and you can feel free to throw fruit, I would say that it's disingenuous to dress all of that up as a patient care issue, because we cannot, the hospital cannot be the beginning and middle and end of the healthcare system, or we will end up in trouble. So we have to look clearly not just at our enemies but at ourselves and know what it is we speak of. So now we move to opposing. We must know how to use the evidence in our favor. You have to know that the evidence is on your side. We can't be wishy-washy about it. If in your heart of hearts you think to yourself, well, maybe it's true that the private sector is really efficient. I mean, when I go to the bank, they get me through the lineup really fast, and they're really nice to me, and they offer me coffee and this kind of thing. And maybe it's true that they're really efficient. So, in my heart of hearts, it may be true, but I still support public health care because I support it based on my values. Then you haven't done your homework. And you need to do your homework in order to make a cogent argument in favor of public health care. So this is why we have think tanks, progressive think tanks, right? And this is what the think tanks on all sides of the spectrum have figured out, that he who can spout the data controls the debate. And we must use data and evidence to support the vision that we put forward for positive change in healthcare. We cannot rely solely on evidence, and the good news is, or solely on values. And the good news is we don't need to, because the evidence supports a single-payer, publicly funded healthcare system. So let's talk about the evidence then on sustainability. Now I'm going to throw lots of graphs at you to make you fall asleep. So, try it again? You say when? So far, so good? No? Now? Yes? Yes. So is Medicare expensive? No. Well, the short answer to that question is yes and no. This chart looks at health expenditures as a share of GDP, or gross domestic product across the OECD. And what you can see in this graph, for those of you who don't have a good visual of it, is that Canada is approximately 6th among developed nations in the world in terms of how much of our wealth we spend on healthcare. So we're not way out of line. We're not way out of line. These guys are way out of line. Our neighbors immediately to the south. But it's actually never a good idea to only compare yourself to the United States of America, because then you feel too good and you never do anything about it. So we're comparable to the rest of the OECD, but we're not in a bargain situation here. We are in the top third of spenders on total spending on healthcare, private and public, everything that we shell out on healthcare as compared to other developed nations. But the difference between us and the rest of the world, if we could move to the next graph, is what proportion of that spending is public. In Canada, 30% of health expenditures are private, 70% are public, and we are at the bottom of developed nations in that ratio. In other words, we spend more than a lot of other nations because we spend so much privately, folks. We would do better to spend more of our dollar on healthcare by pooling our resources and paying for pharmacare, long-term care, dental care, something that other nations have figured out long ago, than in our current financing structure. So I'm not going to argue about whether or not we should pay for doctors and hospitals publicly. That is clear. But I'm telling you that we are behind the times in comparison to the rest of the OECD in our public to private spending ratio. This graph is intended to dazzle you with colored colors, and also to show you that healthcare spending is increasing everywhere, no matter how you measure it. This is not a Canadian problem. It is across the entire world, the entire industrialized world, even the non-industrialized world. And no matter how you measure it, we're sort of in the middle of the pack. Healthcare spending is increasing in Canada, total healthcare spending. But, interestingly, public spending as a proportion of our GDP is quite stable. That's the relatively flat line, relatively flat actually. The red line at the bottom shows you that as a proportion of our wealth, we're spending not very much more now than we did in the 1980s and 90s on healthcare. The upward blip at the end is because you may recall there was a massive financial crisis that hit the entire universe in 2008. So I don't think anybody would blame healthcare for that. But overall, this is a pretty flat line. And so you have to put all of these pieces together in your mind and say to yourself, well, total healthcare spending is increasing, okay? Got it. But public spending, as a proportion of our wealth, is pretty stable. And the Minister of Health and the Premier keep saying that public health spending on healthcare, as a proportion of the provincial budget, is increasing. So, I don't know what numbers they tell you here in Alberta, but in Ontario they'll say something like, 20 years ago we were only spending 30% of our budget on healthcare, and now it's close to 50 or something like that, right? So you guys all hear that rhetoric. How can we reconcile all of these little factoids and pieces of data to get a picture of what's really going on? Well, what's really going on is essentially two things. The first is we are spending more on the private stuff. Most notably drugs. And when I say private, I mean we buy a lot of drugs publicly, but the things that are not single payer, we are spending more on than we ever have in the past. And that is the major driver of increasing healthcare costs, is those parts of the system that are not universally publicly covered. And the second is the pie is shrinking, folks. And so the analogy that I love that Michael Ratos has used many times is, let's imagine you've got a family of 4. And every night they sit down. I can't move yet, I'm sorry, because there are more slides. Can you still hear me? Yeah. The family of 4 sit down at the table and have supper every night, and then the eldest child grows up and goes off to university. And after about 3 weeks, the parents sit down with the younger son and they say, "Son, we're really sorry, but we're going to have to let you go." And he says, "What do you mean?" And they say, "Well, we simply can't afford you anymore. A month ago, you were only eating a quarter of the food in this house, and now you're eating a third of it." That's what's happening in provincial budgets with healthcare. The pie is shrinking. This is spending on Medicare, remember, relatively stable, and this is spending on everything else. If you spend less on everything else because you've gutted your taxation capacity and your ability to raise public revenues, but you don't touch Medicare because you know that that's a thing that will unelect you, you end up with a Pac-Man looking healthcare system. You don't blame that on the flat line. The problem is the size of the pie is shrinking. And this chart, which is very busy, is intended to show you what the impact is of personal income tax reductions on revenue raising capacity from 1996 to 2002 in every province. And what you can see here in Alberta is that effectively the impact of the cuts, tax cuts in Alberta up to the year 2005-2006 has effectively gutted your taxation capacity by 76%. So we as citizens have made choices, have elected governments who clearly ran on platforms of tax cuts. And this is what we got. We got tax cuts. And when you cut the taxes, there's less money to spend on social services, there's less money to spend on healthcare. If you don't touch healthcare, guess what? Healthcare starts to look like it's eating up your whole family budget. And let's not forget the corporate income tax cuts, which have had massive repercussions. So what these bars essentially show you is the amount of revenue lost as a result of corporate income taxes, federal and provincial, from 2008 and projected out to 2014. Coupled with that shrinking of the pie is the phenomenon that I just described to you, which is that those services that are not covered by Medicare, we're spending more on. So this graph, whose colors did not come out nicely here, looks at spending on healthcare in 1975 in Canada, what we were spending it on, and spending in 2009. And what it essentially shows you, the big point of this graph, is that drugs, spending in Canada on drugs has gone from 8.8% to 16.4% of our expenditures. We now spend more on drugs than doctors in this country for the first time ever in the last several years. And there is no sign of letting up. This is what's driving healthcare costs in Canada. Drugs, drugs, and drugs, and a couple of other things that I'll talk about a little bit later. So if you want to talk about how to get healthcare costs under control, you cannot not talk about a pharmacare strategy. But let's not forget the poor boomers. Bob Evans is fond of saying that the problem is that people don't know their geology, because it's not really a gray tsunami, it's a glacier. In other words, it moves not quickly, but very, very slowly. Folks, people only age 1 year at a time. We're not going to wake up next week with millions of old people at our door demanding stuff. People age 1 year at a time, and we already spend more on the elderly and more on the last 6 months of life, and appropriately so, than we do at other points of life. That's when people need the most health care. But it's going to be a gradual shift, and one that can essentially be accommodated by even the most minor expected growth in GDP. The estimate is that it approximately will cost an increase in growth of about 1% per year during that time that the boomers are coming through the system. So the problem is not the aging of the population. It's a myth that the population aging is the problem with the future of healthcare expenditures. But we do have a problem, and the problem is that all of these assumptions are based on all of these figures are based on the assumption that the elderly will continue to use about the same amount of healthcare dollars in the future, and that the rest of us will continue to use about the same amount of healthcare dollars in the future that we have been. And the problem is that assumption is flawed. So where does cost growth in Canadian healthcare come from? This maple leaf graph shows you a breakdown of the different components. And what you can see is that the orange tip of the maple leaf at the very top is the contribution to cost growth from aging. So it's not that aging isn't expected that it will drive healthcare costs, but the contribution is relatively small. These parts are about population growth and inflation, which is not anything that we can do about. But the big lime green bar in the center of the maple leaf is about what we call utilization, increased use of services. Every Canadian is using more healthcare today than we did 10 years ago, or than our equivalents did 10 years ago. More doctor visits, more diagnostic tests, and more drugs. And I would put it to you that we are really not any measurably healthier as a result. So that is the conversation that we need to be having. How much is enough healthcare for all of us in every age group? And are we prepared to allow utilization to continue to grow? And if we are and we're prepared to pay for it, that's fine. But there's no sense in blaming it on the boomers. I use more healthcare than a healthy 36-year-old did 10 years ago. So it's as much my fault as it is anybody else's. So what are the conclusions that we can reach on this sustainability argument? And I hope I haven't bored you to death. The point here is that there is evidence out there. There is evidence out there to combat all of the myths that are being put forward that can be marshaled in defense of public health care, and that actually we all need to do our homework and understand that evidence if we're going to make a substantial difference. So the conclusions then are as follows. First, where spending is growing in healthcare, it is mostly growing in those areas that are privately funded or mixed funded. Second, pharmaceuticals are by far the biggest driver of increasing costs, both publicly and privately. Tax reductions and the recent recession make healthcare spending look like a bigger problem than it is. And aging of the population will not bankrupt the healthcare system. I mean, if you get no more out of this entire hour than that, then I would be very happy. But hopefully, we can give you a little bit more. So is Medicare unsustainable then? We return back to the wisest statement I've ever heard said on the subject. It's just as sustainable as we want it to be. And that, of course, was a quote direct from the Romano report and remains as true today as it was in 2001. So we're not done, right? Because we have exposed and we have opposed, but we have not proposed. And it's vital, actually, that we put forward a positive vision for what healthcare needs to look like. And I don't have any prescriptive advice for any of you as to what those positive proposals should be, because I would expect and hope that every group represented here today is going to take a different angle on this problem and take a different little piece to advocate on. But I'm going to give you a couple of examples of the kinds of messages that you can put out. And there are messages that learn from and steal from the rhetoric used by the privateers and take ownership of that language, and then there are messages that appeal to the better aspects of ourselves. And I don't actually think they're mutually exclusive. I'm perfectly happy with whatever gets the job done. So let's talk about an alternative frame that says something like this. Let's stop using expensive resources in a way that is irresponsible. And to give you a few examples, in the last decade in this country, the number of CT and MRI scans has exploded. MRIs up by 100%. CT scans up by 58%. Remember that those provide radiation to people, which causes cancer. And it's estimated, and this is an estimate from the Canadian Association of Radiologists, not exactly a radical organization, that 30 to 50% of imaging studies are inappropriate or contribute no useful information. 30 to 50% of imaging studies. We are doing imaging on people that contributes no useful information to the management of their clinical disease, and we are all going and sitting in those machines ourselves and racking up the healthcare costs as a result, not to mention the risk of complications and potential harms from over-testing. Private clinics, oh sorry, can you go back one slide? Thank you, that's great. Private clinics or private facilities, something which I know Danielle Steele has talked about as a solution to your wait times problem in Alberta, right? A great report that came out from the Parkland Institute just last week or the week before. Diana Gibson wrote a great report on why delivery matters and shows yet again that for-profit facilities cost more to the public system, and we know that they deliver worse quality. They're associated with higher risks of, with a higher rate of death in long-term care, higher rates of bed sores, lower staffing ratios than the not-for-profit sector, et cetera. So why would we waste money on strategies like that? Drugs we've talked about. It's been estimated that a national pharmacare program could save $10 billion a year or more in Canada, money that we could surely use to do other stuff. And end-of-life care. So, 86% of Canadians say that they want to die at home. And when you ask them how many of you think that you will die at home, the number is 8%. Okay? So we've got a problem, because in addition to the fact that we are not giving people the end-of-life care and the dignified death that they want and deserve, if you get sick and die in the last 6 months of your life, if you started out in a long-term care facility, the cost to the system is somewhere on the order of $30,000. If you were home 6 months before you got sick and died, the cost to the system is approximately $16,000. So we're virtually cutting the cost in half by giving people the death that they want. It doesn't seem rational, does it? And so I think it's an area that we really need to think about how we can rationalize. Alternative frame number 2, if you don't like the ones I just gave you, how about this one? Let's expand Medicare. Pharmacare, long-term care, home care. These are things that each of you, I'm sure, have advocated for at one point or another. Perhaps this is the alternative frame that we need to be putting out there. Maybe, just as doctor and hospital insurance started in one province, in Saskatchewan, maybe it's time for one brave province to take the leap and put in place a single-payer, universal, first-dollar coverage drug plan, even for a very small number of medications that have strong evidence to support their use. And if you don't like that one, then maybe how about this one?
Yeah.
Yes? No? Yes. If you don't want to expand it and you don't want to stop wasting money, then at least you can improve the quality. And these are, this is a small list of what have long been referred to now as initiatives related to the second stage of Medicare, right? Wait time initiatives, which actually Alberta has been a leader on in terms of marshalling resources, interdisciplinary teams, and implementing a single queue to reduce wait times. Team-based primary care, an idea whose time, one could argue, came several generations ago, but now that the medical profession has finally gotten out of the way, is starting to happen across the country. Electronic health records, which we are only just beginning, and Canada, by the way, is the worst in the world in terms of our penetration of electronic health records, obviously among industrialized nations, in primary care. Health promotion and disease prevention, not something that, although you might think otherwise, not something that usually saves money, but is obviously the right thing to do. And better management of chronic disease, which both saves money and is the right thing to do. So there's lots out there. The good news is we don't have to reinvent the wheel, right? Many of these are recommendations that have been brought forward time and time and time again. And our challenge then is how do we shift the dialogue from the defensive, oppositional frame that we seem to be stuck in to a positive, next stage of Medicare kind of approach. And I don't claim to have all of the answers here, but I think that's really where we need to start putting our energies and efforts. So you can pick any of those things, and if you go back in your heart to those fundamental values that we talked about at the beginning, the notion of equity, the belief that access to care should be based on need and not ability to pay, the belief that we want to build a system that is of the highest quality and that provides good jobs and a decent wage for the people who work in it, then the solutions that you come up with will resonate with the public. And they will carry weight in the broader public discourse. But we have to do our homework and make sure that we bring the evidence in to support that message. So that, in a nutshell, is about the shift hitting the fan and what I think should be done better. And at this point, I'd be happy to take some questions. Thank you. And I should, before I finish, point out that the work that I'm involved with Canadian Doctors for Medicare is very much along these lines. If anything that I've said resonates with you today, if you sign your name on the Friends of Medicare sign-up sheet at the table over here, you will get an email from us asking you to join CDM. You can all be members of Doctors for Medicare. You don't have to be a physician to be a member, although there are different types of membership. And we would welcome your involvement. I think that you would all find the work that we're doing interesting. So, who wants to be first?
I'm Kathleen Hammond. I work out of the Provincial Hospital, and I was at a town hall in our neighborhood. I live in Calgary West, and Ken Hughes, CEO of Flingles, that Alberta Health Services started to, be left to become to lead this party. Andrew Constantinitis is the Wild Roser. Marion Ogilvy is the MVP. And so I went to the town hall for Andrew just to see what the Wild Rose stood about and asked the question. They talk about parachuting all this money into the front lines and get away with the management structure. So I was wondering, how do you deal with that type of rhetoric? And so I don't quite know what they mean. Like, they won't give you direct answers when you ask them the question, what do they mean when they're going to do that? And so I was wondering if you've had any, the evidence to support how do we go to these town halls and say, well, what do you mean? Thank you.